Thank you. Okay, so Mike told me I had an hour and a half to do this, so I'm going to try to keep to that timeline because I know nobody else has anything else to do today, right? But listen to me talk. So no, we will get you out by 1:30. I've tried to pare down my talk. I like to talk, so yeah. So as Mike said, I started in Bennington back in the end of September of 2019, just in time to start to get familiar with the area, and moved into town just before COVID hit. So we're still trying to find our way around. Things are hopefully going to open up soon, and we'll get to explore more of the town. But I wanted to spend some time today talking to you about Bennington Rescue, kind of what we do. And I know that everybody, you've seen this truck around. You've seen all of our trucks around. And I think that a lot of people think that it's an ambulance, right? And you call 911, the ambulance comes out, and there's a lot more that goes on behind the scenes, and a lot more that we do it. And I just kind of wanted to touch on some of the things that we do as a service, and then some of the changes that nobody ever saw coming. Or let me rephrase that. A lot of people didn't see coming to this extent. So, all right, let's see. So a lot of times you'll notice people refer to it as we refer to it as the rescue squad. Some parts of the country refer to it as the ambulance. Some people refer to it as EMS. And as Mike introduced me, that my degree is in EMS, or emergency medical services management. And when you hear people refer to of EMS, that's the emergency medical services system. And that's not to say that we just respond to emergencies, but anything that really originates outside of the hospital, and in some cases, in parts of the country, it's stuff that originates inside the hospital as well, that we assist with it. And it's medical in all types of nature. And the service is, sometimes it doesn't originate as a medical call. So that service can be the person who has fallen, doesn't have a medical emergency, but just needs some assistance. So, and it's part of a bigger system, a bigger network. So when we talk about EMS, and I'm going to talk about us, but it really starts with the person who calls 911. That first person engaging the system is the start of that whole service. The dispatcher then provides not only information to the person calling, but provides information to us. We provide assistance to the person. We provide information to the hospital. The hospital provides that care. So it's part of an overall system to deliver care to people who may need it. So on the other side of the screen, we listed our calls for service. So this was 2019. I didn't put 20's calls up there because we're still trying to figure out, how do we count 2020's calls? We'll get to that in a minute. But so in 2019, we had almost 6,000 calls for service. So about 75% of those are calls that originate from 911. So and of that, we spent just about 7,400 hours on calls. And that's just in the ambulance performing that work. That doesn't include any of the downtime or anything, restocking, cleaning, training, all that stuff is not in there. So in 6,000 calls in in our service area, that's a busy service. And to put that into perspective, we are the third busiest service in the state of Vermont. So we showed you the picture of the ambulance, and how many people think that, it has a driver and somebody to take care of it. We've all heard the expression of, oh, there's the ambulance. And, in our field, we hear all the time of people saying, so who's the ambulance driver today? So there's a lot more to it than just somebody driving. And we talk about levels to people outside of EMS all the time. but we never take the opportunity to explain what those are. So I was kind of hoping to spend a few minutes and kind of give you a feel of what goes on from a training standpoint for the ambulance. So we predominantly use 3 levels of EMS provider. So our first one is that emergency medical technician. This is that entry-level ambulance provider. And this is tied to our apprentice program. So we take people off the street who are interested in doing this profession. They come into us, we start paying them from day one. They get training as an EMT. That training is about 140 hours, plus there's also about a 6-month period where they spend time with another provider, honing their skills, unfortunately learning paperwork, because that's a big part of our job, as it seems like with everybody's these days, and also learning the other processes that are involved within our system. So then we move up to the advanced emergency medical technician, or AEMT as we call them. So people who were involved in EMS years ago, if there's any in the group, may have heard of this as the EMT intermediate. That level changed with a 2009 standard change and increased the level of training and the level of skills that they can do. So the AEMT is about another 100 to 120 hours, depending on where they go, of training beyond that EMT level. You have to start at EMT. You can't start at the advanced. So this is where they learn some additional treatments. They get the ability to administer some medications. They learn some advanced assessment skills, and they also learn how to start IVs. So this is kind of that next step towards the paramedic level. Now, as I said, everybody starts at EMT. You don't have to become an advanced EMT to become a paramedic. Paramedic is that next level of certification, and paramedic, depending on where they go, is about another 2,000 hours of training. This is where they learn how to do, intubation. So for those of you who aren't familiar, it's basically allows us to insert a tube in to be able to breathe for you when you can't effectively. They also learn how to administer, a wide range of meds for a bunch of different medical conditions. We do manual defibrillation. We can use a pacemaker. There's a bunch of other skills that are taught in that training. And then after they go through that training program, it's another 4 to 6 months on top of that on the ambulance after they become licensed by the state to get familiar with the specifics of each service. So there's when we look back in 1966 or 63 when Bennington Rescue started, a lot of this training was provided by the Red Cross. In some cases, it was one person who had the ability to drive and somebody who took a basic first aid class, and that constituted the ambulance. The levels have changed and progressed dramatically. It's funny, we had a conversation here just the other day about some of the changes in the field. I've been a paramedic as of this year, it'll be 29 years, and just the changes in that time that I've seen are just dramatic. EMS as a whole didn't start on a nationwide level in an organized manner until 1971. So even though Bennington Rescue started in 63, it was based upon what local needs were, and there was no uniformity in delivery of care throughout the country. So in 1971 was really the start of when there was some more uniformity of care throughout the country. And believe it or not, up until 2009, there was still a great disparity as to what the different levels that I'm showing you on the screen were from state to state. So in 2009, there was a push to try to align those levels of care, because an EMT in Ohio and an EMT in New York and an EMT in Connecticut were not the same. So, that has started to come into alignment somewhat. So, but it does also create a bunch of challenges. So if you're an EMT in the state of New York, that doesn't make you an EMT in the state of Vermont. So you can't take a license from one state and go to the other. Sounds simple, right? Your driver's license goes across the state lines, but your license to provide emergency medical care does not. So who do we serve? So obviously we service the town of Bennington. We service the town of Woodford, the town of Shaftesbury. And our 911 calls account for about 75, it's actually like 74 point something percent of our total volume. And the rest of that volume comes from, southwestern Vermont, the medical center, and also comes from a lot of the area nursing facilities. Anytime that somebody needs a higher level of care that southwestern Vermont can't provide, they rely on one of the area providers to perform that transport from Bennington out to wherever that may be. So, Albany is a common destination of that, but also some to Dartmouth as well. And on this, or not on this list, but one of the things that we support, and in a much bigger role than I think any service has, is the state. And I say in a bigger role than any service has. This has been a dramatic change for us over the past 18 months, is the amount of service that we have been providing, and we as a system, not we necessarily as a service, because all of us have been, whether it's us, it's Pownell, it's, Arlington or Northshire, or any of them have been providing to the state to assist with this COVID response. And that's why I talked about not putting up the numbers that you saw for 2019, because 2020 was a dramatic change for us in what we do. So I put this picture on here because these are two of our apprentices that were learning how to perform some skills. Now, they're on a plastic mannequin. Routinely, that level of training would happen with, the equipment and the plastic mannequin, but the use of personal protective equipment. Who would have ever thought we would be wearing personal protective equipment to touch a plastic mannequin? And it's not that they're doing it to simulate real life. They're doing it because this is how we now have to train our staff, because as you can see, social distancing is not possible when you're trying to teach people how to work in a team to care on one individual. So big learning curve for us there. So it's had a tremendous effect on our call volume. So when we looked back at, those 2019 numbers that I showed you, it used to be somebody called 911. We went to your house, we picked you up, we brought you to the hospital. The hospital couldn't care for you. They sent you somewhere else. We transported you there. That was a majority of what we did. We saw a dramatic decrease. So even though the numbers were going up in the hospital for COVID patients, we saw a dramatic decrease in 911 calls. That started in about the middle of March. We saw in certain months in 2020, and actually up through even February of this year, we've seen months where volume is down about 30% in those 911 calls. So what we're finding is people that don't want to go to the hospital, whether it's for fear that they may be exposed to something, or it's just that they don't want to be out in public. There's also a sense of, or not a sense, but there's also that fact that people are remaining isolated from each other more, and that has helped to kind of cut down on that amount of spread of things like the flu, which normally coming through winter, flu accounts for a big percentage of our overall work. So it had a decrease in our call volume. As a result of that, it was a change to our staffing models. We really started to look at where are we going to put that staff. Normally, we would look at what our call volume is and try to adjust where we put people on and where we staff people based on what history has shown us. So if we know that, from midnight to 6 a.m., we don't get a lot of 911 calls. Okay? Most people are sleeping. Most people don't recognize a medical problem during that time of the night. There are still some. We still have resources available, but we know that that volume is normally lower than. What we found is there's no history to go back to for a pandemic in the EMS field. So, if you look at a nationwide system that started in 71, we can't go back to what we saw in 1928, right? Those numbers don't fly for an EMS response. And also what we found is that every area of the country was different. Historically, if you looked at an EMS system and you looked at volume and you looked at numbers of calls and how people called and why, there was some regularity to that throughout the country. That seems to have gone away during this time. So that caused us to really take a look and start to change our staffing models. And we still, at the end of the day, have to be, our staff and the overhead costs associated with that, we have to make sure the volume is covering. So, EMS, unfortunately, is, as with is a lot of healthcare, is the wrong term, but pay to play type system where, there's a bill that generates in the fact that people get transported to the hospital, but if nobody gets transported, there's no recoupment of any of that cost. So, or historically hasn't been, and I'm going to get into that in a minute. So it changed, some of those services that we offered, because we looked at where can we best help not only the community, but the state in that response to COVID, because we had resources that were not doing some of the things they used to do. So when we looked at that, and the state came forward asking for assistance initially with COVID testing. And I know, as a couple of people had mentioned, that they had been through our facility to get COVID tested. We started working with the health district to provide them with staff initially for COVID testing. That expanded to drive-through COVID testing at our facility 1 day a week, where we were providing staff to administer the test. And then that's transitioned now to a joint agreement with Southwestern Vermont, where they're providing the staff, we're providing the facility, and there's 7 day a week testing here. We've also been providing staff to the state to do COVID testing in people's homes. So people who don't have the ability to get out to a COVID testing facility, they can arrange that COVID test through the state. It's usually through their primary care provider. Will arrange it through the state, and we will go to their house, collect their test sample, and deliver it back to the lab. We've also been out to Bromley. I think some of you may have noticed in the paper over the past couple of weeks, they had done testing at Bromley for 2 Saturdays in February. The state relied on us to perform that testing. And new model for us. That was a test that we had never performed before. And during that time, we tested over 300 people over those 2 days. So we looked at any way we could adjust our services to assist in the response. And the next phase of that is that we're moving into COVID vaccinations. So we're going to be assisting the state with some vaccinations for couple of the long-term care facilities in the community. And we are also going to be starting in-home vaccinations shortly for those people who can't get out or can't get to a vaccination site. So again, things that, 28 years ago, I never thought that an EMS service would be doing. So we're going to go back to that picture where I talk about the changing of our training. Not only have we done training with full personal protective equipment on, but we have done training now we're limiting the number of people that can actually do that in-person training. So you used to sign up, come into an EMT class, you would sit, listen to the presentation, maybe do some hands-on skills. And that doesn't work anymore because we can't bring 10 or 20 people into a room to listen to that delivery. So we transitioned immediately to an online learning model. And the state looked at how they could deliver that online learning model to all of the providers throughout the you know, on a statewide basis. And you know, we offered our services out, and we were selected as the preferred vendor for online services for the state of Vermont. And we have trained well over 100, and I think at this point we're over 125 EMS providers just since August, which is an astronomical amount of providers that we have trained. When you look at our normal training, if we're doing, you know, if we're training, you know, 50 people over the course of 12 months, you know, it was a busy 12 months. And we've done this, you know, our training staff has done this in the period of about 6.5 months. So, but most of it is online. We have gone to where they're actually coming to the classroom, but in small numbers. We've limited it to 5 or 6 per class, where they come in and do their skills. So complete change in our training delivery model. And most importantly, all these changes and all the changes in the way that we deal with patients and responses on a daily basis has put a tremendous amount of stress on our personnel. It's not always the easiest job to go into somebody's house on their worst day. And, you know, we like and encourage our staff to have downtime, take that vacation, get away, and, you know, take some time to distance yourself from what you do on a daily basis. And that's been incredibly difficult. And it's been difficult on our staff and on staff, you know, in this profession nationwide. So we are very much looking forward to the day that people are vaccinated and we have the ability to travel. As crazy as that sounds, you know, just the ability to cross state lines. You know, I know that many of you have seen that, you know, the state is saying that if you have been vaccinated for 14 days, you can now travel. Well, that lifting of that travel restriction does not apply to medical providers. So even though you've been vaccinated and can travel, we can't. So, you know, we are really looking forward to that day when that changes. So, you know, we all love Vermont, you know, even though I've only lived here a short time, you know, not that I want to leave it, but it would be nice to go visit some people. So with that, I don't want to take up too much time because I am sure there's a whole bunch of questions. So this is how you may see us today. So if you look back on some of those other pictures or you look at how I'm dressed today and what you can see in the white shirt with the patches, you probably won't see this very often. What you're seeing on the screen is unfortunately the way we dress a lot of days. But I figured I'd end with the parting picture of our new uniform. And I wanted to give people opportunities to ask questions, and I guess I'll open it up to some questions.
Kristen, go ahead.
Yeah, I actually just have a quick comment and then a question. I averaged your 2019 numbers over a 365-day year, and that's like 16 calls a day. That's pretty amazing, averaged. But my question is the EMT training or the EMT position. The training is just that when they become EMTs, is that a paid position with you folks? And is it a livable wage?
Yeah, so it is a paid position with us. All of our staff are currently paid positions. And is it a livable wage? Well, We have made efforts to increase that wages absolutely as much as we can, and we're going to be increasing again. What we did do, like our apprentice program, is we're taking people with no training and we're paying them from day one as full-time employees. Because what we've found is the workforce in Vermont is tough, and I don't mean that as far as the people, but finding employees is tough. So what we've done is we bring people in who have an interest in EMS. We try to bring in 2 to 3 every quarter. We put them through the training. They're paid with benefits from day one. And then all of those training increments, if they want to go to become an advanced EMT up to a paramedic, that training, they have the opportunity to get paid for through us, and also to have their time in class paid.
That's great.
I have a question.
Sure.
I'm not sure if this is related. You guys do great. We live right next door to the rescue squad, and you guys are always going out, day and night, any time of the day. I always used to worry about it when my kids were younger. If I saw the squad go out, I couldn't breathe until I heard from my kids. Being that I just had COVID down in Alabama, I was wondering, and I haven't been able to get an answer from either the state or for the hospital locally about their position on this COVID infusion of antibodies. I know when I was down there, I think it's just saved me. Within 2 days after I had the COVID infusion, I was better as far as that was. The pneumonia was different, but the COVID, I think I've been jokingly calling them Trump antibodies, but I know I would have been in really, really deep trouble if I didn't have that. And I have not heard anybody up here that has had it. I spoke to one person, Jack Crowther from Rutland, and he said his health insurance said that they would cover it, but that's the only mention of it that I've heard. Do you know if it is a thing yet in Vermont, or if it just we haven't heard of it yet up here? If it's actually being done?
It actually, I saw something the other day out of the hospital out of southwestern Vermont that they've started to do it. I believe that started in the past week or two. So, but I can't say that with certainty that it's been a week or two, but I did see that they have started to provide that.
Well, I know that January 13th, they saw me in urgent care, never saw me, and they said, tomorrow you're going to the hospital and you're going to get this. So I'm glad to hear that, because it is very important, I think. It's a very good tool.
Yep.
Thank you for the job that you do.
Thank you.
Yeah, Carol, go ahead.
Question, what determines whether a paramedic is dispatched or EMT?
So it depends on a few things. So one of the things, it will depend sometimes on the nature of the complaint, if we know it. So there are times when we get dispatched to a 911 call where we don't know exactly what the complaint is. And it also depends upon availability. So we don't have a paramedic in every one of our ambulances 24 hours a day. There's just not enough paramedics in the state of Vermont. So if the paramedic is out on another call, then it's usually we try to get an AEMT out to that other call. So it really depends upon a couple of factors. So, if it comes in for a cardiac related issue, we try to get a paramedic out to that call. Respiratory related issues, either a paramedic or an AEMT is ideal for that. Unfortunately, with the nature of not knowing some of them, and they have the ability to meet up with a paramedic on the way. So sometimes what'll happen is if we have a unit that's out and closer, so if our EMT level truck is closer, we will have them go to the call. They may meet up with a paramedic, either at the scene or en route to the hospital.
Oh, Kristen.
That reminded me of another question. I wanted to ask how many EMTs, AEMTs, and paramedics you have on staff, and it sounds like you use people who aren't necessarily on staff if you need them to.
No, so we all of our so most of our staff is full-time employees. So as far as our paramedics go, we have 8 paramedics currently, 8 full-time paramedics. We have 7 full-time AEMTs, and we have another 9 full-time EMTs, and then we have some additional per diem personnel and some that are also in our apprentice program as well right now.
And is that enough?
No.
Yeah.
No, so we, that the ability to attract quality staff is always been a problem. It was a problem before I got here. It's a problem nationwide. I mean, it's not just an issue in Vermont. It's a tough labor market nationwide, but also it's a tough job to get people to want to come into. I mean, unfortunately, pay rates are what pay rates are, and basically because, we don't have the ability to raise, rates to offset the cost of delivering the service. So people may say that, we should be paying an EMT $30 an hour. We would love to pay them $30 an hour. But the point is, even if we raised our rate, our base ambulance rate, that base rate increase only affects about 26% of the volume that we service. The rest of the volume that we service, those rates are controlled by most of the cases by Medicare and Medicaid. So it doesn't matter. All we're doing is passing that cost on to 26% of that population base. So we're kind of in that catch-22 where, we would like to increase one, but in order to do it, the other has to increase, and that's a difficult situation. And unfortunately, we pay for preparedness. So even though we bill for transport, we build a system based on being prepared. So we're prepared for the call. We don't want people to get hurt or need our service. I mean, I would be happy from a citizen standpoint to say that we had a great service that nobody ever needed. And it was only there when you need it. But from a service standpoint, if nobody needs us, we can't afford to pay the people to make sure we have the good service. So it's kind of that balancing act.
Marsh.
This has been great, Art, and I had no idea of the dynamic ongoing challenges that you all are facing, and the leadership that you provide is really exciting to hear about. The 2 questions I have for you are, what for you as a person are the better parts of your work life, and what are some of the really more challenging, not so gratifying parts of your work?
I guess the gratifying part. So, I went into this career because I was looking for a change. And I know that most people say that, they went in to do EMS because they wanted to help people. I wish I had a great story like that. I don't. I was going to college to be a high school history teacher. I was halfway through college and I said, I don't know if I want to do this. I want to do something else. So I at the time, I happened to be taking an EMT class for no other reason because I wanted to be a lifeguard at the beach in the summer. Not a great story, right? So and so I kind of, somebody said, well, you can do that as a career. And I thought, really? I don't see that. But so I started looking into it, and that's how I ended up doing this. I love what I do. I mean, I love coming to work every day. So, and I said, I've been doing this. I've been in EMS for 30 years. I've been a paramedic for 28. There's not a day that goes by that I would say I wish I had chose something else, except at 3 a.m. when someone's calling with some issue. The first couple mornings are okay. The 4th or 5th one, some days that's probably maybe the least gratifying, but it doesn't happen very often. So, you deal with it.
Thank you.
Tom?
Just a quick question. So I live in Pownell, and there's a Pownell Rescue Squad. Do you guys cross cover, say if Pownell's out on a call or 2 calls and there's no one left to cover? Do you guys work like the fire departments at all, or are you sort of very independent and stay with your respective areas?
No, so we cross with each other all the time. So we have EMS in the state of Vermont is divided up into districts, and we're part of District 12, which is from Wilmington all the way over to the New York line and north to just past Northshire, or Northshire's area, which goes up through Dorset. We have what's called a district-wide mutual aid agreement, so where we will go help each other out all the time. So there are occasions where we will find ourselves in Deerfield Valley, assisting them. We may be in Pownell may be here, Arlington may be in Bennington if we're real busy. We routinely will be in, whether it's Petersburg or Hoosick, New York, providing them with mutual aid. So we cross with each other all the time because it's a system that's designed for what the average shows. There's plenty of times where, you may look and say, well, if we did 16 calls over the course of a day and it takes 2 hours to do a call, we know roughly how many trucks that should be to cover that. The problem is what those numbers don't show you is those 16 calls all came in over a 10-hour window. So you can't plan for all of that. And that's why we help each other out all the time.
Mary?
I can only imagine that your paperwork must be overwhelming at times. So what happens, and I know you had mentioned, if I understood, I don't know a lot about billing and that kind of stuff, but I think you mentioned that you get to bill for transporting people. Mm-hmm. So if you had a call such as Tom was mentioning, and there was a call in Pownell and Pownell people showed up, but then they asked you to show up, who gets to do the billing?
Well, it all depends. So it depends on a lot of things. So it depends on whether the patient went to the hospital or not. It depends on whose ambulance they went in. It depends on who did what level of care. It depends on what the insurance is. I mean, I would love to tell you there's a simple answer to that, but unfortunately, there's not. So, and every insurance carrier has different rules. There's different, so it is, and that's why all of the services employ billing agents, whether they have specific people in-house that are billing compliance people, or they're farming it out to other companies to do it, because it's a complicated decision.
So if you help provide first aid, but you don't actually transport somebody somewhere, can you get paid for that service?
Currently, no.
Oh.
No, I say no. About 90% of the time, no. There's a 10% window there where we can, but it's not. We're hoping to see that expand, and that's one of the things that I think that the COVID response has been great to show, not only from a nationwide level, but from a state level, that sometimes providing that care, like where we're providing the COVID tests and the COVID vaccinations in the patient's home, that it benefits the system as a whole. Because when we deliver somebody to the emergency room, we have delivered them to the most expensive form of healthcare in the country. We know that I'm not making that number up. Mm-hmm. That if we can provide the care that they need in their home and refer them to some other level or some other avenue of care, then that works for everybody. But the problem right now is that if that care is done, then there is no way to recover the cost of doing that care. So even now, if we go out to, the house of somebody who, maybe is a diabetic, and we're able to reverse that situation and get them back to the point where they can make a decision that they don't want to go to the hospital, we probably will not recover anything for the medication or the care that we delivered on that call. So unfortunately, the cost of that is passed back on to the people who get transported.
All right. Well, thanks, Art.